Good morning, everybody. We'll get started in about 2 minutes. Everybody ready to get going? Okay, welcome everybody to the August 28th Medical Education MedEd Grand Rounds. These are, as you know, our GME-wide Grand Rounds, that of which every month we alternate between here at Valleywise hosting it in person and then at St. Joseph's Hospital and Medical Center. These are our Grand Rounds that provide important topics that are not only timely and needed for your everyday clinical practice, but they're also accreditation requirements. And so we found that this was one way to help everybody kind of meet all those needs at the same time, as opposed to either separate or asynchronous learning on your own, right? And we are really pleased today to have 4 presenters for this extremely important topic. As you know, not that, as we mentioned last year, not that I'm biased as a former QI patient safety officer, but today's presentation will deal with event reporting, patient safety, and quality improvement for house staff. This is one of the questions you will be getting on your annual ACGME survey. Do you participate in any of that? And one additional activity for you to recognize. Our speakers, and not in necessarily an order of presentation, we have Dr. Alexandra Hollingworth, who is an assistant professor of surgery here at Creighton University School of Medicine, Phoenix. She is the vice chair of the Department of Surgery and is it vice or associate vice chief of staff for Valleywise Health Medical Center. She is one of our quality improvement patient safety officers for all of GME and the Alliance, and an expert in trauma surgery, critical care surgery, acute care surgery, and many other things. We also have Crystal Garcia, who is the Vice President of Specialty Services and Quality and Safety at Valleywise Health. Dr. Ashwini Arjuna, an Associate Professor of Clinical Medicine at Creighton University School of Medicine, who is also the director, as you can see, of the pulmonary clerkship for our M3s, director of education for the pulmonary medicine division, one of our QI patient safety officers as well, and an expert in advanced lung disease and lung transplantation at Norton Thoracic Institute. And we have Angela Miranda, who is the manager of patient safety and risk services at St. Joseph's Hospital and Medical Center. And so on that note, I turn it over to Ms. Miranda. Thank you.
Hello, everyone. Thank you. My name is Angie Miranda. I am thank you. Manager of Patient Safety at Risk Services at St. Joseph's Hospital Medical Center, St. Joe's Westgate. The Cancer Center, we have two freestanding emergency centers. Also, Dignity Health Medical Group that holds about 1,600 physicians, and Norton Thoracic and Barrow Neurological Institute. So we cover a lot. We use at St. Joe's and St. Joe's Westgate IRIS event reporting. It stands for Incident Reporting Information System. There's an icon on every single desktop and those rolling computers that are there for event reporting. And anybody can get on there and click on it. A student, a physician, a resident, a staff member, anyone can go on there and put in an event report. You'll see in these boxes here, there's, I don't want to go too far away. You can see in the boxes there's different categories in which you can choose. Now, if you happen to be in an event where you are injured, you would use the event reporting employee section on the green section there. All patient-related events are up in that purplish blue section there. And we also review any visitors or motor vehicle accidents. The type of events that we utilize, so we looked at, just took numbers from our fiscal year of 2025, and we did just over 11,000 events. So those are events that are put in for a patient, or there's some type of issue or concern, a near miss. You'll see down at the bottom there, behavioral is usually our biggest. Our behavioral ones include our AMAs, our left without being seen, and any behaviors that the patients are having while they're on the floor go into that behavioral section. So it's usually the biggest. General patient care is the second biggest because there's so many different categories. Sometimes general patient care is just the easiest one to put in there, and then there's subcategories under there.
How are you?
That you could. Not sure. Okay, and if everyone on Zoom can mute themselves, please. There's just some feedback. Okay, so what happens after an event report is placed? When an event report is placed, they all come to Patient Safety Risk Services for review. Whether it's me or one of the other patient safety officers, we review every single event that comes through. The manager or the person who is in charge of the department in which the event happened is, whether it's like lab or one of the floors or an OR, then they have 7 days to review that event. And you as a person who puts in the event report can put your email address on there, and it will notify you when that event is closed so that you know that there's some type of closure there. And then we just close them out. If it ends up being something that we need to review a little bit deeper, we will do that. And that's going to be talked here in just a second. We do all of our severity scoring using NCC MERP. So it goes all the way from no harm, no error, no harm. And these are good catches that can be put in all the way down to our I-9, which is a serious safety event and patient death. So you can see the different color categories and the severity of it gets more red as it goes down. So our serious safety event algorithm, is this event related to a patient care? If it was related to patient care, we click yes. Was there a deviation from the generally accepted performance standards? Sometimes there is a deviation, sometimes there is not a deviation, or sometimes we're not sure if there was a true deviation. It's not clear. And then we get together as a team and review those a little bit deeper. So did the deviation reach the patient? Yes or no? And then did the deviation cause moderate to severe harm or death? And then that goes into those two separate categories. So this is still our fiscal year, and you can see our E5s down there all the way up to our I9s. Those 5 categories there are more intense categories. They take a lot of review, a lot of investigations on them. And E5, so something with patient harm that has a deviation, we review every Friday as a team, all the patient safety officers. We review them and confirm that severity level. F6 or above, we take those to the executive leadership and we review those on a weekly basis if it's an F6 or above. If it has a known deviation or a serious safety event, we review those within 24 to 72 hours as a group. And that includes the physician, the staff members, the residents, everyone who is involved in that care. We meet together, we do just a little quick debrief, and then we can go on from there to more intense, including action plans. So I have an event involving a resident here. I'll kind of go over it with you, and then I'll just ask you guys some questions and have you kind of come in. So this was a female at 26 years of age with a past medical history of asthma, schizophrenia, post-traumatic stress disorder, borderline personality disorder, and intentional overdoses. She was brought in by ambulance to the ED for evaluation of dyspnea and possible stridor that started at approximately 2230. The patient's Columbia suicide score was a 3. The RN disclosed this to the resident. The resident acknowledged. No suicide precautions were put into place by the RN or the provider. So the patient was inspiratory and expiratory upper airway squeaks with some suprasternal retractions and was treated with racemic epinephrine respiratory treatment and had great improvement. They were just going to kind of hold this patient for a little while to see how she did and how she responded to everything. At 0313, the call light was pulled out of the wall. The patient was found to have the call light cord wrapped around her neck, unresponsive, positive ligature marks on her neck. A code blue was called and the patient was intubated and family was notified. So is this event related to patient care? Yes or no? Did the deviation from generally accepted performance gaps, was there a deviation found? Yes or no? Yes. Did the deviation reach the patient? Yes. Did the deviation cause moderate to severe harm or death? Yes or no? Yes. All right. So out of this, yes. That we didn't put the suicide precautions into place on the patient because the suicide Columbia score is considered a moderate and should have suicide precautions put into place until further evaluation, including social work or psychiatry if we needed. So what would we score this at? Temporary harm, permanent harm, interventions required to sustain life, or patient death? Interventions required to sustain life. She had to be intubated. So should this be reviewed further? Yes or no? Yeah, so we did do lots of review on these ones. So what did the investigation reveal? The RN communicated the Columbia suicide score of 3, but did not communicate that it was moderate on scale. She did not have that verbal communication with the provider. The RN did not know that they could just put in suicide precautions into place prior to the provider assessing the patient. The resident did not know that the score of 3 was considered moderate and did not place precautions or have social work consulted. And then the RN assumed the provider assessed the suicide precaution skills and did not have a questioning attitude. So we put wonderful actions into place on this event. So what does the follow-up look like? Patient safety risk reviews all events. If the event meets the criteria of an event investigation and analysis, which is one of our reviews that we do, then that will be conducted and until the review, interviews with the staff, finding the root cause of the event, and oftentimes leads to various actions to be put into place. If the event does not require an EIA, we're followed up. They continue to follow up and review with the department leadership. If the event requires peer review, this is completed through the quality department. Patient safety risk services is not involved in peer review. And thank you.
So I'm Crystal Garcia. So from on the Valleywise side, again, the Vice President of Specialty Services, Quality and Patient Safety here. So in the quality department here on Valleywise, we do have two patient safety program managers, Jamie Gidley and Samantha Habitus. So if there's ever any questions regarding around entering a patient safety event into our system, please reach out to one of those two. Or just if you have questions about patient safety in general, they're a great resource that can be utilized, and they're very helpful and great to have. So our event reporting, why is event reporting in response important? It's very important to help us reduce have reduction in errors here. Again, we don't know how to fix things if we're not aware of them. So our reporting system is great to be able to do tracking and trending, and having the eyes from the providers and their frontline staff to be able to let us know what's out there and what's happening and what can be done differently. Again, it helps us develop those correction actions. It's not to be able to enter a patient safety event. It's not being punitive. It's just for us to help get better as an organization and to develop those corrective actions. And we learn from each event that comes through. We're able to learn from that, and we're grateful to have the system and be able to utilize it in that manner. Again, believe that some of our barriers to, we don't always get great reporting at times. We have seen over the years it's gotten better. But again, it can always be better to be able to get those patient safety events and get that reporting. Some believe that reporting does not contribute to improvement, which is, a false. We do make great improvements. I'll show some items that we're doing around that improvement that because of information we're getting from our patient safety events. Lack of involvement by physicians and other providers in the event reporting system. We want to include all of the providers into our reporting system. We know you guys see a lot of things, and again, being able to report that is very important. We utilize MIDAS here. You might out in Valleywise, some people will call it Check It. It was just a different name that was created. But MIDAS is the system that is where it's entered. They're both the same for patient safety events. So on the Divine that we utilize our intranet here, you can go on underneath the apps, and onto the left side, you'll see it there. And that's where you enter your patient safety events. Again, as Angela mentioned from St. Joe's, they also utilize, if it's a workplace violence, there's an option there. Same for Valleywise. It says workplace violence. It's still into the MIDAS system. It just utilizes a different format. So again, there's two different ways, and we encourage, again, reporting in both platforms or into MIDAS for workplace violence. Again, it's very important to input so we can make improvements in that realm, as well as for patient safety. Again, how you enter, again, when you go in, there's two different areas. It says risk, and the other one is patient relations. So risk is the one you check for patient safety events. Patient relations is if there is a concern from a patient is complaining about something. Maybe they're complaining about their food, or complaining that the nurse didn't communicate well. Again, you would enter it on that side. Again, if you just have questions, just enter it on the risk side, and then we're able on our end to correct if needed. As there's event classes, these are all that are out there that are listed: behavior events, falls, diagnostic errors. There's, different ones to pick. Again, if you're not certain, please, pick what you feel is closest to it. The program managers are able to determine if maybe it was put into the wrong category, because this does play into how we pull the data. So again, they're able to make sure it resides in the correct area. Again, making sure we select the patient, non-patient, use only if there is not a patient involved. Maybe it's a visitor. That is an option. Also, you're able to enter anonymously, but we also like if you use your name, and that's why we are able to follow up if there are some more questions. But anonymously is an option if you don't feel comfortable with putting your name in. Again, we need to enter the ID. The ID is the MRN number that we utilize. And then the ID type is the MRN. One thing I want to say, we are actively in the process and getting really close to, we will have a link in Epic that you'll be able to just click on the link in Epic and it pre-populates and it takes you into the system, and it'll be a lot quicker to be able to enter this information. So in the coming weeks, we will be sending out information, and we'll make sure that you guys as residents get that information in that process. But we're really excited to be able to have that and make the process even easier to be able to do reporting. Again, once it pops up, you got to select the patient's name. Again, and you got to launch the form. And once you do that, then you're able to type in the information you want to share. It's under comments, and you type in what the concern is, and then the information will be there. Just a couple of the do's and don'ts. You know, when you're doing this and you're entering the information, we want to make sure you're using factual terms. We don't want to reference that a patient safety event has been completed in the medical record. There has been times when that has been done. We don't want that to occur, because then that can open us up from a legality, and you know that can be discoverable. And these currently your patient safety events are not discoverable. They're under our patient safety product that we have here, and so that just gives us safety protections as we're doing this in a quality and a patient safety realm. Again, we want it to complete it as soon as possible. Again, if it's done as soon as possible, then the facts you remember them better. If it's done later, it's kind of hard to exactly maybe what happened. And so again, as soon as possible is important. Use accurate spelling and grammar as much as possible. Enter as much information as you can as relevant to the event. Do not document accusations, speculations, or conclusions regarding the event. Again, it goes back to the first, just the facts, you know, what happened. Again, do not print, duplicate, or copy the patient safety event. I do believe we have locked down Midas to where only there's a select few that can print these events. And the reason for that, again, is once it's printed out of the system, used to printing was available, but if it was to be printed out of the system, it kind of gets, you know, passed along, then that again breaks the protections from your patient safety work product that we have, because now it's out of the system and others can see it. So we definitely have locked that down. Once you're done with entering the information, again, make sure you hit submit, and that to save your work. You don't want to do all the work and enter it and not hit that. And there is a time limit on these as well. So please, there's a little time limit on the bottom. Please pay attention to that if it's taking a little longer, to make sure it don't time out on you and the work is not saved. So please, that is important. Some of our patient safety event data, we do break it down here. We do have our hospital, we have behavioral health, and we have ambulatory, because we do track these in all areas. As you can see, we're run for inpatient-wise between about 400 to 500 a month that we see. Again, I know this is small, and I apologize, but behavioral events here, as well as at St. Joe's, as Angela is saying, is one of our main events that we do have. We have seen an increase in specimen labeling and handling, so we are working on that from a patient safety perspective. And then our behavioral health events, of course, the main one there as well is behavioral events. And behavioral health, they do have to enter a lot, and they do enter the anytime there's any allegations of, even if a patient just making a simple statement, maybe they have abuse or any of that, they do enter, and they do a lot of follow-ups. So they do a lot in behavioral health, and they do very well with entering these. For behavioral health, the second one is safety and security. Again, with a lot of our patients, that is, a concern, and there is some, we do monitor that closely. And then falls, we will be working with behavioral health this upcoming year, even closer on our falls that we have in that area. And then our last one is ambulatory. Ambulatory, our main one here is dialysis that we see. The dialysis enters a lot in regards to any time someone comes off a dialysis treatment, 15 minutes, at 15 minutes, they will enter. So that's why we see when those patients want to come off a little early, they do enter those into system. The second one, again, for ambulatory is safety and security, and so we do monitor that. This is just one of our, I talked about falls. So some of our falls data that we saw out of our patient safety events, we have seen inpatient wise having some issues. So we have a new falls committee that's working and meeting on a regular basis. They've done some implementation around our iBeds that needs to go live, some of our new fall scores. And as we can see, initially we are having small timeframes in between falls, but as we continue to work through this group, with the information we're receiving around falls, our falls length between falls is getting longer. So we can see that the action items that we're doing is helping by us having less falls and longer time in between those falls. As I was mentioning, chair alarms, we're going to be having some chair alarms rolled out at Valleywise. And again, there's just an active committee. And again, we welcome any residents. We do have a new patient safety committee that that's specifically focused on patient safety that meets once a month. We welcome any of our residents that want to join. Let us know. We'd be glad to have you to join that. There's a lot of work in that committee around falls, pressure injuries, specimen labeling. So also for patient safety, we are looking at, root cause analysis that we have here. Again, can't stress enough, the RCA helps us learn from the events. A lot of times, these events are serious events that have occurred. So, there's been a death or significant patient harm that's occurred in these events. And so we definitely learn it's not again, it's not punitive. It's not looking at individuals when we get in a room. It's looking at the whole process of what's happening. And so with that, the clinician participation is just vital. We get a lot of information that can be shared and that can help develop action plans so we ensure that it doesn't happen again. Some of the common categories, surgical errors, diagnostic med errors, equipment errors that we see. Sometimes, fall if a significant injury occurred due to a fall. With that process, we start the investigation, very similar to St. Joe's, 24 to 72 hours together to get information, do some interviews, try to get individuals into a room and continue gathering that data and then analyzing the data from that event. Create recommendations and then make sure we complete and do that follow-up after those recommendations are created, that then we're able to, make sure they completed what they said was going to be started. One of the things we're doing, I just wanted to, we utilize the data that we've received from, our patient safety events. We've noticed that we've had an increase in our 2 patient identifiers. So making sure that everyone in the organization uses those 2 patient identifiers for the patient and not skipping that step. And again, that's part of the communication. And so we have a group coming together for early September to work on this process. With this, because we've seen a lot of, sometimes 2 patient identifiers have played into a few of our events that we've had recently, and so, as well as with like gathering labs and making those, so that goes into some of the diagnostic errors. So as you can see, we've seen an increase, and so we've had a total of 409 altogether that played into the 2 patient identifiers. So we're going to do this before some major significant event happens. So that's our next big project. Any questions regarding our patient safety? We do appreciate everyone's participation. Again, can't stress enough the importance of, if you want to join, we would love to have you at our committee. And Dr. Hollingworth, I think you had your slide at the end, or? No.
Okay. Well, if you join the patient safety committee, you have a very easy time with your project for sure, because we did have a project that we did with the patient safety quality committee, and it was basically because of not only events that were reported in Midas, so the residents, attendings were reporting in Midas, the quality committee also found a trend, an uptrend, and this was in the fascial dehiscence. So first we noted that some of the suture was breaking, and even the attendings noted fraying of suture. So we were asked to report these in Midas, and this would be the equipment failure. And then the quality committee noted the large increase in fascial dehiscence. So formed a subcommittee and started to analyze our data, collected data. The students were involved as well. So you can have your medical students help you with a literature search, and they really helped with that. Then we found what were our current conditions, what was happening with fascial dehiscence. We noted a few things. The first one was we did have a lax in oversight with the attendings watching the fascial closure. A lot of the times the attendings were leaving when they started to close. So there was less oversight. Another one was a big change in suture company. That was change that happened pretty significant for us to get used to that suture, and that's what we were noticing, the frame. So after that, we did our RCAs, and we decided that we would change. The first thing we wanted to change was just the knowledge that this was happening and sharing the data. So part of the ACGME requirements are to share the data, and we did share the data with the attendings at the monthly meeting and the residents. The residents were more shocked than the attendings, and they did not know this was happening. And so just the awareness alone got them to pay more attention to their closures. We also asked the attendings to please be present for the closure and have oversight. Of course, technique is important. However, it's hard to get trauma surgeons and general surgeons to agree on a specific technique. We're not going to agree on the 1 centimeter or 5 millimeter. We're not going to do that, but eventually we do want a standardized closure. This alone, the awareness and oversight, started to decrease the rate of fascial dehiscence. And then we had a very quick change to Ethicon suture. And I have no connection to that suture, but that's just what we use here at this facility. And Dr. Iskander was instrumental in getting that changed. And we found our dehiscence rate decreased by 80%. It went from like the 18 range. I had it on my poster. We had a poster last year in May to down to a little over 3. And now it's down to the 2 range. 2.30. So that's more than an 80% change now. It's probably closer to 90% decrease in fascial dehiscence. Now, one of the errors, well, we couldn't really avoid the suture change that happened so quickly, but we weren't sure exactly which factor was the most important in this change. So you'll find when you do your projects, you might not have control of everything. There's another study going on with wound vacs, incisional wound vacs that was going on. That might be also influencing currently the small decrease as well, but we had no control over that. So you're going to find that there's things happening in the hospital you have no control over that might be influencing your particular project. But this is a great example. The students, the residents were involved in this project. They were not involved in the committee, but if you do join the patient safety committee, I highly recommend it for your future knowledge and also for your projects. It would really help you understand the process better and to tie these event reports and the quality metrics that you get and will be getting on a monthly basis and turn it into a project for you. So this project won for high value care because, of course, decreased not only just the fascial dehiscence, but going back to the operating room, we're going to the ER and seeing, coming back or several procedures that we need. So that's basically what I wanted to go over in my slides, but they're not present. And I will hand it over to the next speaker, Dr. Arjuna.
unmute. So the moral of the story is they already finished my slides, so we are done for the day. Now we are. So the end of this talk is going to be about trying to give you in a nutshell what this entails, why is it important, and why do we keep talking about this and harping on this for the 3 years or the 4 years or the 5 years you're here doing your residency and fellowship. This is a very important take-home point which needs to be met by all residents and fellowships and all training programs. So why do we do this? The numbers keep going up every year. Patients die because of many annual errors and medical errors. 1/3 of these patients could have had very easily preventable patient errors or mishaps that could have totally been caught in time and prevented. Both of us have, physicians and residents have poor involvement because we do not know what we are looking at, and half the time we don't even report it. Reporting is essential because that's how we learn. Again, both the speakers mentioned it very well. It's not punitive. Nobody is trying to get you. It's just for us to learn the system to be able to develop into something that doesn't happen the next time in the future. The best part of the story is history keeps repeating itself because man never learns, right? We don't learn if we don't report it, and we do not learn if we know from what we have made or made mistakes from before. Good culture. Bottom line is to be able to create that culture and environment for better patient care as well as patient satisfaction. One of the pearls of any system, academic or private hospital system, is patient experience. And it stems from the beginning part of their journey when they enter into the hospital till the time of their discharge. And many events can happen in between these 2 points. And one of the things that we can prevent, we can work on is to make sure that their experience is the best. Education, this is ACGME objectives. It's a part of our education on patient safety. Create this culture, know how to report adverse events, near misses, close calls, and unsafe conditions. Experience in patient safety investigations and follow-up. Nothing gets complete if there is no accurate follow-up to the events that have been reported. Clinical site monitoring of the resident, that becomes a teaching process to both for faculty members engagement as well as patient safety initiatives. And at the end, it's all about resident fellow education and experience in disclosure of events. Very many barriers. We need to understand the barriers before we say why we do not do what we do, because of a lot of things that happen. Lack of culture, workplace safety. We do not have the knowledge. How do we do it? Why do we do it? When do we do it? I'm too tired to do it. And should I actually do it? Lack of skills. Nobody taught me how to do this, but we have had so many orientations to go through this, but still we'll realize, oh, should I even go ahead and do it? Fear, what if somebody is going to come back? Again, these are not accusations, clear stating of facts as to what happened. And at the end of the day, it's ownership of all team members. We are a group working together. Medicine is never practiced in solo. It's a group effort of everybody to be able to make it the safest practices for our patients. We learn, we improve. There is less litigation. That's the real man's world. When you finish training, all of us are now protected under the mentors that you have. But when you go back to the real world, one of the things that we face about these events and patient safety reporting is litigation. Knowing how to be able to handle it and have the right documentation to support what you did for the patient.
I need to sign something.
For their nuclear cases.
Lower costs. It brings about a lot of integrity among members, creates a very good interprofessional learning environment. It improves the morale of the PT members. It's healing. You know, when you vent it out, when you get a situation taken care of, you can vent, you can heal, and you can make the process better. Patient needs, simple truth. Patients do not come to us asking for complex understanding of their medical problems. Simple, explain them, state the facts, give them, be empathetic, emotional support, recognize and validate their emotions, accountability, including apology. There is never, when you are in wrong, it's never too late to say sorry. And all of these help us prevent future prevention. When I keep doing this for years and years after, sometimes I question myself, why is it all about patients and why is it not about physicians? Trust me, doing this process and being able to be involved in it also gives us closure as physicians, and we will be satisfied too at the end when we go through these event reporting events and we close the loop about what happened in this particular situation. Comprehensive model includes you identify the event, activate the systems, response and disclosure of what actually happened, and then we go into the root cause analysis, which involves investigation and analysis, and finally what the resolution of this problem was of the patient safety event was. This is pretty much what Crystal covered and how they go through these processes to be able to finish or close the loop of an event that got reported in the system. What happened to the after effects of it? The response to the harm, how do we mitigate it? How do we prevent it? And goals of investigation. Remember, it's always protected. It is interdisciplinary. It's never in silo. It's never alone. All the different involved systems, groups of people get involved. It's interdisciplinary. Human factors are always put into, their expertise is put into consideration. Very timely, as you can see, most of these events get done within 7 days, 24 to 48, 7 the max, and leads to broad performance, process improvements. And this is how we come up with all kinds of protocols. The quality metrics for the hospital, fall preventions, CAR-T, CLABSI, line infections, dementia prevention. All of these quality metrics from the hospitals came back from what we learned with many of these events that got reported in the past. So again, this gives us evidence to practice medicine in the best realm possible. And this feedback, this helps us disseminate this information further to the rest of the group, the rest of the hospital, so that the practice becomes the norm. A practice becomes very clear, foolproof, and transparent to the entire system. Systems approach, we don't redesign, we can't redesign ourselves, right? We can't redesign humans, but the goal is to be able to help redesign a system in which we can all work together and we can work in a very safe environment. Human error cannot be eliminated. No matter how much you look through, how much of help you get from the entire surroundings, we can't eliminate errors. After all, we're all humans. But we can look at these misdirected resources and focus on what can be improved, causes culture and changes the way we look at the entire situation. So there's no name, blame, shame, or train mentality that replaces it for us to be able to promote secrecy, working together, and being able to express our feelings very openly. It is also about reducing harm for the future, harm for the present, harm for the patient, and for ourselves and for our own practice too. Ask what is responsible and not who is responsible. Then focus. Once you know what made this happen, then who made this happen, the solutions start to get more clearer and easier for us to get through. Involve patients, very important. Issue and recommendation. This is a simple task. I said patients may not know about their healthcare systems. Do not make assumptions, ask them. The more you ask, the more you learn. Concern about legal protections. You always know there are the leadership's involvement in this. Your faculties are involved in it. So ask questions and know the local QI privileges that happens in each settings, and invite patients in appropriate settings. Further distress to the family. Timing matters. You have to solve them when it is the right time. You can't go back in time or redo, lessen the harm that's already happened. And remember, it is not one size fits all. People come, situations come in different directions and different sizes and shapes. So we should be able to cater to and tailor to the each needs as we go by. Best way to involve patients and family in individual or group interviews, feedback, surveys, and at the end, close the loop with the clinical education for entire team members who are involved. Post-event reporting. Again, communication is the key. Remember, the disclosure, it's a process, it's not an event. It took a whole bunch of processes for us to get there. Explain what happened, describe the implications for the patient, offer genuine expression of apology or whatever it is once the event gets disclosed. Plan for an investigation, never gets complete without an RCA or a PDSA cycle for something for the future to bring about a change. How this recurrences can be prevented. Always establish contacts, support groups, and a follow-up. This cannot be possible. You and I cannot be make this foolproof, cannot make this transparent if our organizational leadership is not involved in this. So it all comes down to us being able to have these information clear and succinct for our organizational leaders to be able to help us through this event reporting and patient safety initiatives. Where do we stand? So 1/3 to 2/3 of these errors are not disclosed. It's so funny. This number hasn't changed since I was a resident 10 years ago. So it takes a lot. It takes a village to make these changes to come through. Even when a disclosure happens, it does not meet patient expectations. That's something that we still keep working on. And clinicians, most of us often lack disclosure training. So if I were to ask in this class, in this group of people, and again, ValleyWise is open to ask, how many of you have ever done an event reporting? Oh, good job. I see a hand up. Okay, good. How many of you are doing one and never did one? Good. Friend, others can also put their hands up just to make me happy, but looks like nobody wants to. How many of you have gotten a closed loop communication, meaning got back and heard what happened to your event? Good. That's an attending. Good job. And then lastly, how many of you, after listening to this, I'll give you examples. Examples are the biggest factors to help you do the better for your future, right? Look at the examples I give you at the end, and then it makes you feel how many of you at the end of this lecture will think about reporting an event or a patient safety activity. Sun, hi, everybody. Okay, fair enough. So let's see there when we get there, okay? There are questions to follow at the end. So what happens to resolutions? Discussions with the patients and families after the initial event. It's a huge process. As Angela, Angie, and Crystal mentioned, lots of people are involved. There's always a closed group analysis that takes place. We explain it in the time of the events and what led to the resolution of the event. And we also bring about both financial and non-financial disclosures. So oftentimes we do not get involved in that, but if there is a very serious event, we do get to know and understand the metrics which are involved in getting to this patient safety event for a resolution. That's one of the reasons why we have patient safety officers, risk managers, organizational leaders, vice presidents, and people who have a little bit more bandwidth to be able to get better solutions for us when we do operate in such a setting of patient taking care of patients. In a nutshell, always assess the event. Process implementation is important. Organizational improvement and sustainment. This is what makes us to be able to have a very good training as we finish whatever years of training that we go before we enter the real world. Giving you a small example, our goals, even you know how the system looks. This is how the icon on the desktop looks. Check it, and was a huge QIPS project that got presented at our QIPS symposium, and one of the very well processed projects that we did in May of 2025. So something that is seen, is used, but never implemented. So think more about it as you go on to train from the future. So for some reason, this does not want to work. Okay, this you know how it already works. Epic, as Crystal said, they're trying to create a link so that we should be able to go through the patient chart easily. And then I would give an example which caters to my needs, because I do a transplant. So I'm going to give you two examples. One, which I've not put over here. So we had a gentleman who came into the floors for shortness of breath. He was supposed to get some transbronchial biopsies as a lung transplant recipient. Transbronchial biopsies are very easy for us. We do it. Oftentimes we have no issues. Everybody was involved in this signed. So he came in sick, so the patient was sent with IV antibiotics. Timeout was performed in the endoscopy suite. Anesthesia was given by the anesthesiologist. Just before starting the procedure, before I put my forceps in, I saw a bag of heparin running by. So transbronchial biopsies can bleed. When they bleed, it's very difficult to control airway bleeding. Many a times, if it's very significant, because you can't block off the airway. You'll have to have a plan B to figure out, can I block this side, that side? You should have a plan, because if it starts to bleed too much, you will be lost in the pool and lose the airway. The pulmonologist opened and we went ahead and stopped the procedure. And then we realized that instead of shutting down the heparin before the patient went down to get the procedure done, the nurse accidentally thought that had shut down the IV pole, which was running the antibiotics. So there was a mishap between trying to stop what and send the patient down with the wrong pole, which was not supposed to be the case. And everybody assumed it was antibiotics and not heparin running. And this was an easy miss, which was caught early on, and nothing happened to the patient. But then again, something that we learned from this process is, how do we prevent this further? Events noted, we stopped it. The nurse had given the information to the nurse who came on to the morning shift. The floor nurse was busy doing and taking care of another sick patient, so she just sent it down without explaining to the family, explaining to the nurse in the endoscopy suite. Endoscopy suite did what they did, but they did not go through what antibiotics or heparin was running. Then finally, we had to stop, right? We did not do the procedure because you have to hold the heparin for a certain amount of time before you poke somebody's lung. So we had to stop, and we had to explain in very clear facts to the patient. It made him stay another day for him to get the procedures, him or her to get the procedures. But again, if we did not stop, and if I just went ahead and done it, we could have caused more harm than being safe in the situation. Once this outcome was closely followed through with all the staff members involved, we came up with a different protocol to be able to do a correct checkout for our transbronchial biopsies in the endoscopy suite. So another example that I want to give is, which is this comes to my mind, is Crystal mentioned about specimens being named wrongly, and something which we have seen the number of patient safety events get higher and higher. One of the things that we saw, it's a huge harm, which we can't even think about, but it was caught in time, was any of our fresh lung transplants come over here before the recipient goes into the OR, we do a sickness check. Make sure they're not having or harboring any infection. So the two things become very important, a COVID swab and an RVP, just to make sure they do not have influenza or anything else. Even if they have it, we have tools to take care of it, but a COVID is a huge thing for us. So we had a patient with a very long name and another patient with a very long similar name, a COVID swab for both. And interestingly enough, it switched between these patients, and the recipient who was supposed to get these lungs came back COVID positive. The lungs are on their way back from Colorado. We can't discard these lungs. Those are some heavy lungs. Somebody died for these lungs. We get through, we do not know what's going on. I ask these patients the same questions again. Are you sick? Anybody sick? Nobody, nothing's going on. So we go to the next level. Should we keep a monolupivir, which is an monoclonal antibody? Should we treat the patient before he goes into the OR? What's happening with the cyclic threshold? And then for some reason, each team member needs to be involved. I just asked the nurse, can you just cross-check if the sample is correct or not? And it takes us 30 minutes for us to figure it out. He's on his way to the OR. We have to have a plan for this person who just treated COVID positive. Either I'm going to lose this set of lungs, I can't find a different recipient, and this person who has been sick enough to wait for a lung cannot get the lung. So 3 people get affected by a single event. Thankfully, caught in the nick of time, it was a wrongly named specimen for a different patient, and we did a re-swab again. We were smart enough to send another swab just to make sure we are not missing anything, and it came back negative. So simple things like these can prevent a huge harm, and the spectrum can go a long way. So the moral of the story is, it's not punitive, it's a responsibility. Try to work towards the safety of yourself and your patients, and learn to be able to report it without thinking that it's going to come back and haunt at you. So patient safety and event reporting is a huge part of all of your ACGME training requirements. And remember, it's a team effort. And if you need anything, we're always there to help you and guide you through. Patient Safety Committee, which is a new initiative, I would very much encourage the residents to be a part of, to learn what quality, as it's a huge learning tool during your training process. Questions? Thank you, guys. Okay, how do I mute this one?
Thank you, everyone. We will also have a feedback form coming up. Please fill out some feedback, and then we do have an exit room pretty quickly. There is a leadership meeting right after us. So thanks again.